Hi, my name is Josh Neumiller. I'm a pharmacist and diabetes care and education specialist. I work as a professor of pharmacotherapy at Washington State University in Spokane, Washington. This particular slide here shares some of the key cardiovascular outcome trials from agents in the GLP-1 receptor agonist class. And what I have done is shown in red to highlight those outcomes that were statistically significant. Fortuitously, these studies have also found benefit on cardiovascular outcomes, and shown here in the red box, really honing in on that primary outcome of 3-point MACE for most of these trials, those particular hazard ratios in 95% confidence intervals. You'll notice the 3-point MACE is shown here as red and significant with the leader trial with liraglutide, as well as with injectable semaglutide and dulaglutide. And these are the three agents that currently have expanded indications for cardiovascular risk reduction. Now, about whether these lower cardiovascular risk in people with CKD, that's certainly an area of great interest. We also have evidence from meta-analyses to help answer this question of some of the cardiovascular benefit of these agents in these subpopulations. This was from a recent meta-analysis that included all the cardiovascular outcome trials I just shared, in addition to 3 additional trials. So it's provided some evidence to answer the looming question of whether or not GLP-1s plus SGLT2 inhibitors further improve cardiovascular benefit, and actually supported some recent statements in the ADA standards of care suggesting that we can consider combination therapy in these individuals to further mitigate cardiovascular risk. So as shown here in this slide, this is looking at that meta-analysis that included the wide spectrum of cardiovascular outcome trials with agents from the GLP-1 receptor agonist class. And here we're specifically honing in on the subgroup analysis, looking at people based on their baseline EGFR of either less than 60 or greater than or equal to 60. So you can see there the rates of 3-point MACE by baseline EGFR for those on GLP-1 receptor agonist therapy versus placebo. And if we look further at absolute risk reduction and number needed to treat in these two populations, if we extrapolate that out, absolute risk reduction for those with an EGFR less than 60 is 2% versus 1% with those with an EGFR greater than or equal to 60, which equates to a number needed to treat of approximately 50 for those with an EGFR less than 60, or 100 for those with an EGFR greater than or equal to 60. So while this does have limitations as would be associated with a meta-analysis, certainly data substantiating potential benefit of these agents in cardiovascular outcomes for people with CKD.